Okay, good morning. Good morning, everyone. I'm so happy to see so many people early morning before 6:30. They have already joined, and by the time 5 minutes will get over, almost there will be 100 people. So this shows that the teaching session which is we are doing at 6:30 is very useful for everyone. So today again there is a lecture, very important lecture, that what exactly we should do. Various catheters. Sometime IV catheter, sometime you will find a patient with a central line getting palliative chemo, and you are also looking after that patient. So how you should take care of that catheter? Foley's catheter is very common. So how we should take care of Foley's catheter, and how we should take care of simple IV cannulation. So Swati is our faculty in our department, assistant professor, and very bright assistant professor. And once she took this class for residents, and I realized that this class is very important for the whole of the audience early morning, those who are joining. So I have requested her to take this class for us. So you can see she has written a lot of papers, and she is really interested in teaching and practicing palliative medicine, and she's teaching a lot for our palliative medicine residents. And whenever we give a class to moderate our palliative medicine resident, she is moderating it really well. So Swati, please go ahead and deliver your lecture, that what are the practical points we should take care when we are looking after the catheter at home or in the hospital. Thank you, Swati.
Good morning, ma'am. Thank you for the introduction, ma'am. I'll just share my screen.
So keep your questions ready with the Arun. Arun will sort it out, and we will answer at the end.
So the topic for today, as ma'am has already explained, is the catheter-associated complications in palliative medicine. Prevention is better than cure. The overview for today's class will be, we'll be discussing the different type of catheters we use in the palliative medicine, or the general medicine. We use the different type of catheters, their complications, and how to manage them. Coming, the most commonly used catheter. The most common catheters which are used in the medical setup are the vascular and the extravascular catheters. The vascular. Hello.
Yes, ma'am, we can hear you.
But the slides I cannot move.
Down, if you click on the screen, and at the bottom there might be that bottom left, some arrows might pop up. Yeah, there.
Okay. So the vascular catheters include the peripheral IV cannulas, the arterial cannulas of the catheters, and the central venous catheters. Whereas the extravascular catheters, which we'll be discussing today, include the Foley's catheter and the pigtail catheters. Coming over to the vascular catheters, this is a simple peripheral venous cannula we are all familiar with. And we all are very familiar with the parts of a simple IV cannula, which has a luer lock plug, a needle grip, and then injection port cap. We can see the catheter wings, a valve, and a catheter and a needle. Now we see that these catheters, IV cannulas, are available in different sizes. And the sizes, they are in the gauges, and as the gauge keeps on increasing, the flow rate keeps on decreasing, because the length of the catheter, it keeps on decreasing. So we see the 14 gauge IV cannula is the largest, with a flow rate of about 240 ml per minute, whereas the 26 gauge cannula is the smallest, with a flow rate of about 13 ml per minute. Coming over to the complications we most commonly associated with the IV cannula are pain at the injection site, formation of hematoma, extravasation of the drugs, sometimes air emboli, or arterial cannulation inadvertently. They can also be infection or needle stick injuries to the healthcare workers. But the most common complication is the phlebitis, which is associated with the IV cannula. Now, phlebitis, we see that the incidence is around 20 to 40%, and it is caused by mechanical or microbial or any chemical irritation of the vessel wall, leading to thrombosis. It is most commonly seen in females with the use of large catheters with IV drug administrations, and if the catheter is used for prolonged period. However, the treatment is simple. We should remove the IV cannula where the phlebitis has developed. Limb elevation and an anti-inflammatory gel application will be helpful. Coming over to the next set of catheters, which include an arterial cannulas. There are two types of arterial cannula, and other is the arterial catheter. So in the picture, you can see a 20 gauge arterial cannula on the left side, and on the right side, we can see a 4 French letter catheter used for arterial cannulation. Now, what are the indications for putting an arterial line? They include an accurate beat-to-beat BP monitoring in patients of critical illness or major hemorrhage, where we need to have a beat-to-beat BP recording. Then in some patients, like the bariatric patients who are very very obese, and in them locating an IV line is very difficult. The use of a non-invasive BP cuff gets difficult because the size is not available. Or in burn patients where we cannot use a non-invasive BP cuff. Then in patients with critically ill patients where we require frequent blood sampling. So in these patients, we have to put an arterial line. Now, the complications which are associated with arterial cannula, the most common is an arterial vasospasm, which occurs in about 25 to 57%. The other common complications are arterial catheter occlusions, formation of hematoma or hemorrhage. They can be emboli, sepsis or bacteremia, or permanent ischemic damage, pseudoaneurysm formations, and accidental drug injection. However, we see the most common is arterial vasospasm or arterial catheter occlusions, and the other are the incidence of other complications is less. However, the most deadliest complication, the incidence is very less, about 0.02 to 0.001%, but it is the most deadliest, that is the accidental drug injection. Now, what do we do if in case we have an accidental arterial drug injection? So first we have to understand that what is the mechanism of arterial injury after drug injection. This is a vessel obstruction by the inert drug particles. This leads to a cycle of platelet aggregation and vasospasm in the artery. And this cycle will actually lead to thrombosis of the artery. Then this will compromise the blood supply to the digits, which can lead to gangrene. So we can see the course of events which happens after an accidental arterial drug injection. Initial reaction will be there will be pain on injection, there will be flushing, numbness, and weakness. Then we can see after 30 minutes to 2 hours, the nail bed pallor will be there and capillary refill time will be decreased. Then within 24 hours, there will be skin mottling, cramping, phlebitis, paresthesias, motor deficit, finally leading to muscle swelling, digital edema. They can be contractures, or there can be development of compartment syndrome. Then within 1 week, there can be permanent contracture, and it can also lead to necrosis, gangrene, or auto-amputation. So what do we do in case of an unintentional arterial drug injection? So, the main points in the management would be a symptomatic relief, management of arterial spasm, re-establishment of blood flow, and treatment of sequelae and long-term rehabilitation. So many people, they say that we can remove the arterial cannula once we suspect that there has occurred an inadvertent drug injection. But some evidence in literature states that we can keep the cannula in situ and start 0.9% saline infusion through it. This will be helpful if we need to administer certain drugs like to prevent vasospasm in the artery, and also if we have to inject a dye to look for what all damage has been done. So we can keep the cannula in situ and start a 0.9% saline infusion through it. Then the other drugs which can be used to prevent the damage is heparinization, which will decrease the vasospasm and formation of thrombosis. Steroid therapy, some people advocate steroid therapy. Then vasodilator therapy. IV analgesics to be given to manage pain, and antimicrobials to prevent secondary bacterial injection. Then the use of sympathetic ganglion block for pain relief. Other treatments would be limb elevation, massage, physiotherapy. Doppler ultrasound should be done every 24 hours. And in severe cases where we find that there is development of compartment syndrome, upper limb fasciotomy can be done. The important part here is that rehabilitation is very important. There was a case in literature where there was a young male about 20 years old where there was an inadvertent arterial drug injection, and they managed him. He developed compartment syndrome, and he was managed with fasciotomy, but he ultimately it led to amputation. Now this patient, because he was young, he lost his productive years and he got into depression. So as palliative care physicians, it is very important that we rehabilitate the patient after such an injury. Coming on to next set of catheters, which are the central venous catheters. Now, as in oncology setup, these central catheters are used very commonly to deliver the chemotherapy substances. Now we can see that central venous catheters, they are available as non-tunneled percutaneous central venous catheters, central venous catheter, tunneled central venous catheters. There are also implantable ports, and then there are peripherally inserted central catheters. Now, in non-tunneled, which percutaneous central venous catheters, we see that they are used in ICU or emergency department, and they are used for short-term access. Whereas tunneled central venous catheters, that like Hickman line or PermaCath, they are used when a long-term we require a central catheter for a long period of time. Then we have implantable ports again, Portacath and Infuser port, which is available for long-term administration of chemotherapy drugs. And we have PICC lines. These are also for short-term access. Coming over to the non-tunnel CVC, which are seen, they are placed in a large vein. Veins like IJV or subclavian vein or femoral veins are used. They are usually 15 to 20 centimeters long, and they are available in 3 to 8 French sizes. So for days to weeks, if we need a central venous catheter, then for it is very useful for short-term access. And they are mostly used in critically ill patients on multiple drug infusions in ICU. Coming over to the tunneled catheters. Now here the catheter is first put into the vein, then it is tunneled into the skin because we have to maintain it for a long period of time. So tunnel prevents the infection and provides stability. Then there is also low infection rate due to a Dacron cuff surrounding the catheter near the exit and the entry side, and can be used for weeks to months after insertion, usually for patients who are on chemotherapy. Coming over to Hickman catheter, it is named after Robert O. Hickman. He was a pediatric nephrologist in Seattle Children's Hospital, and he developed this catheter. It is used for administration of chemotherapy and other medications. It is again a tunneled catheter. Coming to PermaCath, they are split catheters. They have double lumen, as we can see in the picture. They are 2 lumens of unequal lengths and one opening a few centimeters distal to the other. It was mostly used for hemodialysis purpose. This is a tunneled catheter set. We can see there are dilators. There is a peel away sheath on a dilator. We can see the dual lumen, the dialysis line. Then it is a metal tunnel, a puncture needle, and a guide wire through which we access the vein. Coming to implantable ports, and the most commonly we see Portacath is used. The catheter is left here. The catheter is entirely under the skin, and there is a port which is also under the skin, and this catheter is accessible through this port. Some ports, they have a reservoir that slowly releases the drug once injected. Then port is accessed through a Huber pointed tipped needle, and it is used for chemotherapy and blood analysis. There is low risk of infection than the other CVCs and PICC lines, and there's also less chances of obstruction, and it requires little daily care. Everything is inside the skin, so the patient can just, the daily care is very easy to perform. Just take a bath and keep the site clean. Now, peripherally inserted central catheters, when we see, they are the central venous catheters which are inserted in the veins of the arm, like the cephalic and the basilic veins. They are very long because they have to course through the whole arm and into the IVC. They are about 50 to 70 centimeters long and shorter in diameter as compared to CVCs. They can be single or multiple lumen and can be kept for more than 6 months, and they are suitable for home therapies. Coming over to the antibiotics and the antiseptic impregnated catheters. Now, they are the chlorhexidine silver sulfadiazine catheters and the minocycline rifampicin catheters. Now, CDC recommends that antiseptic or antibiotic impregnated catheters need not be used on a routine basis. Only if if we are taking proper measures to prevent infection of the central catheters, like maintaining strict asepsis while putting them, and then proper catheter cares. If the rate of infection for the CVCs are low in our ICUs and medical setup, then we need not use the antiseptic or the antibiotic impregnated catheters because they are very costly. So they should be used only if the catheter is expected to remain in place for more than 5 days, but if the rate of catheter-associated bloodstream infection is not decreasing, even after successful implantation of a comprehensive strategy to reduce the rate, that means they should not be routinely used. Coming to the cost comparison, we can see the antibiotic coated CVC is about 4,500 to 6,000 rupees, whereas the other, we can see the percutaneous central venous catheters about 2,000 to 5,000 rupees. So hence there is no, we should not add the additional cost of this. Then these catheters are little expensive, permacath, hemodialysis catheter and portacath, but they are for the long-term access. Now, what are the complications we see with the central venous catheters? We have immediate complications. These are that occur during or closely following the central line insertion, and the other are the delayed complications, which are much more gradual in onset, and they occur in weeks to months after a central line insertion. Coming to the immediate complications, they can be cardiac, vascular, pulmonary, or catheter placement complications. Coming to the cardiac complications, they are like while putting the catheters, central catheters, we can have arrhythmias, and they should be managed accordingly. The vascular complications most commonly associated with the use of CVCs are arterial injury, venous injury, bleeding, or hematoma. And we can see with the use of ultrasound, the risk of these complications, they have decreased. Coming to the arterial injury, the incidence of arterial puncture during a central venous catheter placement is about 4.2 to 9.3%, and it is most commonly seen while we put the central venous catheters in the femoral lines. Then artery often recognized secondary to its characteristic pulsatile flow, but in patients with low blood volume, it may be difficult to diagnose. So the important point here is that what should we do if we have put a catheter into the arterial artery? Should we immediately remove it, or should we keep it followed by pressure application? Now, we see that both these things, removing the arterial catheter or keeping it in situ, both have risk. Now, if we keep the catheter in situ, there can be stroke, thrombus, or potential neurological complications, whereas immediate removal of the line with pressure application may lead to hemorrhage, pseudoaneurysms, or AV fistula. So what should we do? So it is recommended that leaving the accidental catheter in situ followed by a quick repair, it carries less morbidity and mortality than performing a catheter removal with pressure. So keeping the catheter in situ will be more helpful and helpful in reducing morbidity and mortality. So what do we do in case of an inadvertent arterial drug injection? You should leave the catheter in place. So if the catheter is still in place and we suspect the arterial injury is surgically easily accessible, then we should go for a repair of the artery. And we should, but keeping in mind that a neurological evaluation should be done along with it. If the site is not easily accessible, then we should do an imaging. And if the site of the arterial injury difficult to expose, we can do a percutaneous treatment with covered stent or percutaneous closure devices, followed by a prompt neurological evaluation. However, if we have removed the catheter, then we should do imaging to evaluate the arterial injury, and we should do a prompt neurological evaluation. Serial clinical follow-up should be done for airway and neurological changes and control of hypertension. Coming to management of pseudoaneurysms or AV fistula formed post-catheter removal. Once we have removed, then chances of pseudoaneurysm or AV fistula formations are there. If we suspect a pseudoaneurysm, then compression or image-guided thrombin or coil placement can be done. However, if AV fistula is formed, then image-guided coiling should be done. If treatment is delayed, then of course direct surgical repair to be done. Coming over to venous injury, during insertion, the guide wire becomes trapped against the vessel wall, and subsequently we insert the dilator or catheter. Then the wire, this happens while wire bending or pushing against the vessel wall. So it can lead to laceration, injury of the vena cava, mediastinal vessels, or the right atrium. So how do we manage? Again, management is by surgical repair, direct suture, or complete vascular reconstruction. If, however, there is a life-threatening hemorrhage, which is very rare, then urgent ligation of the bleeding vessel can be done. Coming to rare complications like hematoma, which is reported in about 4.7% of all the cases. They are mostly benign, but some can become a source of infection or abscess formation. Management will be a CT guided drainage in them. Then abnormal anatomy we can have sometimes, which can cause complications, which can be a left-sided vena cava is seen in 0.3% of healthy population, and potential complication can be a systemic emboli or cardiac arrhythmia. Now, how do we do? Sometimes guide wire entrapment can occur and the guide wire can be resolved. Then an imaging should be done, and there should be an attempt to remove the guide wire. Sometimes a surgical intervention might be required. Coming over to pulmonary complications, the pulmonary complications noted while putting a CVC catheter is pneumothorax, a chylothorax, air embolus, tracheal injury, or recurrent laryngeal nerve injury. Now we see the pneumothorax, which is seen in about 1% of the cases. It is most commonly during the subclavian central line insertion. Then as we increase the number of attempts and we place a large catheters, the incidence of pneumothorax can increase. So how do we manage? It depends upon the clinical scenario. If the patient has increased respiratory distress or a hemodynamic instability, then a needle decompression in the second intercostal space can be done and followed by an ICD insertion at the fifth intercostal space. If the patient does not have a respiratory distress and we can see that pneumothorax is small in size, then high flow oxygen will help and spontaneously the pneumothorax will resolve. Coming to the chylothorax, we see that it is most commonly during the attempts to place the central venous catheters on the left side, left IJV or left subclavian vein, because the thoracic duct is close by. So how do we manage iatrogenic chylothorax? Now, if we suspect that a thoracic duct injury has occurred, we should do a conservative treatment, that is thoracic drainage for 2 weeks. So many cases have reported that with conservative treatment, there can be resolution automatically. However, if the leak persists, we can see what is the volume of the leak. If it is less than 200 ml, then we should continue the conservative treatment for another week. It will finally resolve. However, if it is still persisting, we should follow this pathway where the leak, if it is more than 200 ml per 24 hours, we should do a video-assisted thoracoscopic surgery, identify the leak and close with the clamps. If still with the VATS we are not able to identify the leak, we can use a fibrin glue or a talcum, and we will see that it might resolve, but in very, very rare cases, the leak might persist and an open surgery might be required. Coming over to air embolism, we see that small air embolism might happen, but they are of little significance and can be self-resolving. However, a large air embolism can occur, and we can see how do we detect this. The patients might present with anxiety, dyspnea, dizziness, substernal chest pain, agitation or disorientation. The signs to look for in air embolism include a tachycardia, tachypnea, altered level of consciousness, severe hypotension. A mill-wheel murmur is very characteristic of air embolism. There can be sudden loss of consciousness or cardiac arrest if the air embolism is too big. Coming to the diagnosis, we can see a precordial Doppler is essential. And we can see it is most sensitive and a non-invasive modality. Esophageal Doppler can be used, however, it is an invasive modality. Then ABG, chest X-ray, ECG, can be performed. Now, how do we reduce the risk of venous air embolism during CVC placement? We should be very careful while putting a CVC. We should first avoid and treat hypovolemia before the catheter placement. During the catheter placement or removal, patient should be in supine with a head low position, and if awake, then asked to hold the breath. Maintain all the connections to the central line, dock when not in use. An infusion regime should always be set up to create a siphon of more than 20 centimeters in the infusion systems. Now, in case of suspected air embolism, we should lower the head end to prevent cerebral embolization, aspirate the CVC in Durant's position, 100% FiO2, and pressure and inotropes if needed. Coming to recurrent laryngeal nerve, it is a rare complication which is seen about 1.6% with central line insertions. Tracheal injury is very, very rare. It can occur, and if it occurs, then a surgical repair might be needed. Coming to occlusion of the catheter, occlusion catheter can be occluded. It can be a mechanical occlusion, a non-thrombotic, or a thrombotic occlusion. Mechanical can be kinks in the catheter. It can be a positional occlusion, the catheter resting against the vessel wall, or catheter malposition, secondary to poor dressing technique. Non-thrombotic complications can occur due to intraluminal obstructions or poor flushing volumes in between incompatible medication. Then thrombotic complications, it is a late complication of central venous catheter. Coming over to the delayed complications, the most important are infection, which is the catheter-related bloodstream infection, and the catheter-related venous thrombosis. Coming to the catheter-related bloodstream infection, we can see the incidence is about 80 to 189 per 100,000 patient years, and the average annual cost is about 16,000 to 550 US, and patient mortality is around 12 to 25%. But in Indian scenario, they found that there was a study which was conducted in the Indian Tertiary Care Teaching Hospital during the last decade. The incidence in India ranges from 0.2 to 27%. And most commonly, we see that the CRBSI, the highest prevalence rate is in the neonatal ICUs compared to any other ICU settings. Now, how do we diagnose CRBSI? The IDSA has given a definitive diagnosis, which requires one of the following: that we should be able to isolate the same pathogen from both the central and the peripheral vein. And the single bacterial colony count should be at least 3-fold higher in the sample from the central line as compared to a peripheral line. Then same organism should be recovered from percutaneous blood culture and from the quantitative culture of the catheter tip. And there should be a shorter time to positive culture. That is, we can obtain the culture from a positive culture from the central line 2 hours earlier than we obtain it from the peripheral line. Then this is the CDC defines the catheter-related bloodstream infection as an exit site infection or a tunnel infection. The exit site infection is that which is typically less than 2 centimeters around the catheter exit site, and the presence of exudate will be there. In the tunnel infection, the inflammation will be beyond 2 centimeters from the exit site of the catheter, and there will be exudate only when we press the whole subcutaneous tract. When we press, there can be pain and tenderness, and there can be exudate can be seen, can be expressed by palpation. Risk factors, we see that the use in ICUs, and we see that the neonatal ICUs, they have the highest incidence. Then as the hospital days increases, the site of catheterization, the type of insertion techniques, maintaining ASAP. If we have not maintained asepsis, then number of catheter lumens, if we place it for a long time, all these factors, they are risk factors for development of central line associated bloodstream infection. Now we see the National Healthcare Safety Network data. This is worldwide data. We see that the order of pathogens will be the most commonly associated organism with CRBSI are gram-positive organism, that is the coagulase negative staphylococci. However, in Indian setup, we see that this study which was performed in a tertiary care center, here we see that 752 isolates, that is 80% of the infection was due to the gram-negative organisms. So it is different from the world data. Now, we all see that the catheter infection, it begins with contact. So maintaining strict asepsis is very essential during putting of a central line. So there are modes of contamination through the whole length. We can see right from a contaminated infusate, then the lines, if they are not proper, then not maintaining the catheter properly, all can lead to a source of infection. Now, the CDC, they have recommended a CLABSI bundle for prevention and treatment of catheter-related bloodstream infection. Now, insertion bundle, the 5 key components which they specify are hand hygiene, which is very, very important. Then maintaining maximal sterile barrier precautions during insertion. Use of 0.5% chlorhexidine solution with alcohol for skin antisepsis. Then optimal catheter site selection with avoidance of femoral vein, because femoral vein have the highest incidence of infection. And daily review of the line necessity is very important. And once we see that line is not necessary, then it should be promptly removed. Now, post-insertion, again, while dealing with central catheters, every time we should perform a hand hygiene. Again, daily review of the line is very important. And we should check for the dressings. It is recommended that we use a semi-permeable dressing so that we can see underneath the dressing, the catheter is visible, and it should be changed after every 7 days. But if it gets soiled due to any reason, then it has to be changed. Then administration set replacement for continuous infusion should be changed. No more frequently than 4 days, but at least every 7 days. Lipid or blood infusions are given, then it should be changed every 24 hours. Then sometimes in ICUs we use propofol, then infusion through the central lines, then the tubings have to be changed every 6 to 12 hours. And all the infusates should be prepared with aseptic technique, and healthcare personal education and training is very important. Management is, if we suspect a CRBSI, then empiric therapy, we should cover both the gram-positive and the negative organisms and draw the blood cultures, and then we should target therapy according to the blood cultures. This is the duration of therapy, ideally 10 to 14 days, depending upon the organism, whichever we get through the culture. Then coming to, we see that first it was reported that CVCs and PIC had similar line rate of CLABSI, but still we see that the median time of development of infection was longer in the PIC lines as compared to central lines. So PIC lines is a safe alternative for prolonged inpatient access. Coming to the catheter-related venous thrombosis, we can see that it can be an asymptomatic catheter-related thrombosis or a symptomatic catheter-related thrombosis. Asymptomatic will be present as CVC dysfunction, where we have inability to infuse or withdraw blood, whereas symptomatic will be present with edema, discoloration at the insertion site, or ipsilateral upper extremity edema. And CVCs, they are the most common non-malignant cause of the SVC syndrome. Diagnosis, we have American College of Chest Physician guidelines. They have given a score, Constant and et al. Have proposed a score, and according to this score, which given a 1.2 each, like venous material, CVC, localized pain, unilateral edema. However, if we have an alternative plausible cause, then a -1 score will be there. If the score is more than 2, then a upper limb DVT is very likely. Coming to the management, we see that there are guidelines by the American Society of Clinical Oncology. They recommend that TPA can be given depending upon the clinical status of the patient and to restore the catheter patency. However, if there is a CRT has been detected, then a 3 to 6 months of anticoagulant therapy with low molecular weight heparin should be given. Routine thromboprophylaxis is not recommended in cancer patients for prevention of thrombosis, and however, routine flushing with normal saline is recommended. CVC removal should only be done if thrombosis does not respond to the anticoagulant therapy. However, first we should not remove the central line. We should start with the anticoagulant therapy. Again, then the National Comprehensive Cancer Network, they again say that anticoagulation should be recommended, and it should be ideally done for 3 to 6 weeks once we have a detected case of CRT. However, routine thromboprophylaxis, they also do not recommend. So, now coming over to this study, where we see that incidence of central venous associated catheters and the central venous thrombosis, catheter infections and thrombosis, we can see that any complication, they are greatest in the first 90 days of the catheter placement. Now, we see these two graphs. We can see that patients with baseline cancer, they have higher rate of development of catheter complications in the first 90 days as compared to patients with no baseline cancer. And why is this so? Because we see that cancer is a state where patients are on immunocompressive cancer therapy, so there is a risk of infection. Cancer is itself a hypercoagulable state, so the risk of thrombosis will always be there. Coming to poor survival of cancer patients, we can see that they this might be a reason for reduced contribution to the lengthier catheter time periods, and increased severity of complications in cancer patients in the first 90 days can be a reason for their earlier removal. Coming to the key points, we see that numerous complications are associated with central venous catheter. These are the mechanical complications which are present at the time of the catheter insertion, and infectious and thrombotic complications usually occur later. With the use of ultrasound and increased operator experiences, the fewer mechanical complications are reported. And measures to prevent catheter-related infections include appropriate infection control measures, proper hand hygiene, skin antisepsis, maximal barrier precautions, and timely removal of catheters when their use is no longer required. So with this, we finish the vascular catheter section. Now moving on to the extravascular catheters, where here we will be dealing with Foley's and a pigtail catheters. Now Foley's catheters, coming on over to the complications, we can see the short-term and the long-term complications. The short-term complications associated with Foley's catheters are trauma, bleeding, formation of a false passage, paraphimosis, hematuria or UTI, and the long-term are colonization, urethral stuffing, stones, hematuria, or obstruction or stricture formation. Coming to trauma, urethral trauma or injury can occur in both men and women, and this is usually where there's a forcible catheterization in urethra which can cause spasm, and it may also lead to bleeding or formation of false passage. Paraphimosis occurs when the foreskin is not retracted back over the glans after Foley's catheterization, and the foreskin trap behind the corona forms a tight band of constricting tissue. The treatment in this case will be ice application, mechanical compression, pharmacological therapy to manage pain, then a dorsal slit surgery in extreme cases. Coming over to the most common complications which we see with the use of Foley's catheter are urinary tract infections. They are the most common healthcare associated infection, and they increase the morbidity, mortality, and length of hospital stay, which can cause economic burden on the national healthcare system. Now, the IDSA has proposed a catheter-associated urinary tract infection definition, which is presence of symptoms or sign compatible with UTI with no other identified source, along with 1,000 colony-forming units per ml of one bacterial species in a single catheter urine specimen. We can see more than the UTI associated with catheters, they account for more than 30% of the hospital-acquired infections. It is the fourth most common type of healthcare-associated infection, and the rate of CAUTI is 3.1 to 7.5% per 1,000 catheter days in acute care hospital. Now, how the patients with urinary catheter can get infected? And this is like, firstly, again, asepsis has not been maintained, where the skin where the catheter is placed can be dirty. So organisms from the environment can travel along outside of the tubing into the bladder, and hand or glove, if it touches the catheter directly and antisepsis has not been maintained, then it is a source of infection. So symptoms will be, patient will present with fever, suprapubic tenderness, costovertebral angle tenderness, altered mental status, and flank tenderness. Coming to the complications, it can lead to urinary catheter obstruction, bladder urolithiasis, purulent urethritis, prostatitis, or urethral stricture. Risk factors are age, which is more than 60 years, and female patients in urinary retention or incontinence. Some having diabetes mellitus, they are more prone to the urinary tract infections. If there are disconnection of drainage system in patients who are immunocompromised, like the cancer patients, they are higher risk of CAUTI. Then as the duration of catheterization increases, the risk of CAUTI increases and can lead to renal dysfunction. And in patients with renal dysfunction also, they are more prone to UTI. The most commonly associated uropathogens are the gram-negative bacilli. Most commonly is the E. coli, around 21.4%. Now again, CDC has proposed, similarly as they proposed a CLABSI bundle, they have proposed a CAUTI bundle for prevention of UTI during insertion of Foley's catheter. Now the most important step, they say that insert the Foley's catheters only when appropriately indicated. So this is the foremost step in preventing CAUTI, that if the catheter is not required, do not put the catheter. Consider alternative for Foley's. Then if the catheter is needed, then strict asepsis has to be maintained while putting the catheter. Daily perineal care alone only in patients with diarrhea or incontinence should be there, and avoid breakage of the closed drainage system. Place a bag below the patient but above the floor. Use a clean patient designated container for emptying the urobag. Ensure unobstructed urine flow. Avoid kinks in the tubing. Daily review of the catheter during rounds is again very important. And when we think that the catheter is no longer required, it should be removed. Then use of electronic or visual reminder to alert caregivers that Foley's is in place and it should be cared for. Now, strategies not recommended for CAUTI prevention, they are the complex urinary drainage systems like antiseptic releasing cartridges and raincoat is not required. Changing catheter or drainage system at fixed intervals will not prevent your CAUTI. Only if there is a clinical indication like obstruction, infection, or a compromisation of the closed system, then only you require to change the catheter. Routine antimicrobial prophylaxis is also not recommended. Cleaning of periurethral area daily with antiseptics when catheter and C2 will not help prevent. Only if the patient has diarrhea, then it is required that the patient cleans the area. Irrigation of bladder, installation of antiseptics or antimicrobials in the drainage system will also help not prevent the CAUTI. And routine screening in asymptomatic patients for use of Foley's catheter or for UTI does not help in preventing the UTI. Now, if we suspect that the patient has developed a UTI, we should first obtain a urine culture prior to start of the antibiotics. It is important that we replace the catheter at this stage if the patient has symptoms of UTI, because we need to remove the source of infection. Urine sample for culture should be collected by removing the indwelling catheter and then placing a fresh Foley's catheter. Aseptic technique should always be done while collecting a sample, and culture result, once we get a culture result from the urine sample, then we can proceed with the targeted antimicrobial therapy. How to collect the urine sample for culture is very important. Then once the patient has presents with symptoms of UTI, firstly remove the indwelling catheter. Then insert a new catheter using strict aseptic technique. Occlude the catheter tubing a minimum of 3 inches below the junction of catheter and the urotubing. Then disconnect the catheter from the urotubing under aseptic technique, and urine should be collected in a sterile container. Then how do we treat? If symptomatic, we have to change the Foley's and antimicrobials should be started. And according to the blood culture report, we can change the antibiotics. But however, if the patient has asymptomatic bacteriuria, we should change the catheter and do not treat. Then antimicrobials are not required unless the patient is undergoing any urological intervention, pregnant patient, or immunocompromised patient. The key points here is that the most effective way to reduce the incidence of CAUTI is to reduce the use of urinary catheterization by restricting its use to patients who have clear indications and by removing the catheter as soon as it is no longer needed. So this is the most effective way. The other points given in the guidelines, that maintaining strict asepsis, maintaining closed drainage system, they are also important. But the first key point we should always keep in mind that unnecessary catheterization should not be done. Coming to the last, pigtail catheters, which we most commonly see in the palliative setup. They are the drainage catheter, they have side holes in the tip side, and there's a one side is coiled end and it resembles a pig's tail, and hence it is called a pigtail catheter. The sizes available are 6 to 16 French, 30 centimeter long. They can be kept for a maximum period of 3 months. They are usually used for draining of non-viscid or non-coagulable collections of bile, urine, pancreatic fluids or pleural fluid, or even air in case of spontaneous pneumothorax. But we should always Keep in mind that the only wherever the fluid is non-viscid or non-coagulable, then it can be drained by pigtail. If the fluid is very thick, then drainage by the pigtail becomes difficult. We can see a pigtail catheter set. The palliative medicine residents might be familiar with these set: a stainless steel needle with a sheath, then a radio opaque pigtail catheter, a pigtail straightener is available, and there is a catheter and a needle assembled. Then we can see on this chest X-ray, there's a pigtail catheter. We can see the coiled end on the X-ray, it is visible. Now, uses, it can be used as an nephrostomy tube. Then it is used as an intraperitoneal fluid drainage for abscess, bile, pancreatic fluid, ascites, or urine. Most commonly, it is used for the pleural fluid drainage in cases of malignant pleural effusions. Then the pleurodesis can also be done with it, with installation of sclerosant, and imaging studies sometimes that use tracer dyes, they also use the pigtail catheters. We can see that they are simple to put. Comparing them with ICDs, they are smaller, less painful, and they cause less tissue disruption. However, because they are the diameter is less as compared to ICDs, they are prone to more kinking, obstruction, or clogging. But for a long period of time, if we have to place a pigtail, if to place a catheter, then pigtail is ideal for the patient comfort. Then once we have drained the fluid or whatever indication for which the pigtail was put, then we have to remove the pigtail. We should clamp the catheter and disconnect from the drainage bag. Cut the hub of the drainage catheter and release the strings. This string sutured pigtail catheters were available previously, but now we have a simple pigtail catheters which can be just removed after cutting the sutures. Then complications we can see of pigtail, we can see that their lumen is small, so they are more prone to kinking or obstruction or dislodgement. Infection might occur in where we keep the pigtail for a prolonged period of time. There can be visceral injury, which are rare, and might occur. Rare complications are very, very rare. There are case reports in a 67-year-old man who developed an impaired vision immediately after pigtail catheter insertion, and his CT findings showed that he had developed multiple cerebral emboli, which were postulated to occur from air entry into the pulmonary vein. Then another case reported was of subclavian artery laceration during the removal of the pigtail catheter, because it was placed in the first intercostal space, which led to massive hemorrhage. Then another case report was a pigtail catheter was inadvertently placed into the left ventricle in a 3-year-old patient. However, these are just case reports and these complications are very rare. Pigtail catheters are safe to use. The key point is that the pigtail catheter provides safe, reliable, and effective drainage of the pneumothoracis and free-flowing simple effusions, and it is a reasonable alternative to tube thoracostomy when applied to appropriate patients. Thank you.
Thank you, Swati. Thank you for a absolutely wonderful overview of catheter-related infection. Arun, are there any questions?
Yes, thank you. Only one question for you, Dr. Swati. I think in the earlier part of the presentation, you mentioned about vasodilators and steroids. So the route of administration, is it intra-arterial or intravenous? That is the question.
No, they are intravenous only. We should give them, because we're just keeping mostly we remove the arterial cannula, but if we are just maintaining its patency. But vasodilators and steroids need to be given IV only.
Thank you. That is the only question. Ma'am, you have to unmute yourself, please. We cannot hear you.
So if there are no questions, if we have to understand that how important this lecture is, that do not place any Foley's catheter unnecessary, do not place any unnecessary central line catheters. If at all patient isn't with Foley's catheter, what is the way we can collect the sample for? Because when patient is with Foley's catheter, a lot of recurrent UTI happens. So how we should collect the samples and how we should take care of the simple IV cannulation. I think absolutely wonderful presentation, Swati. So I just want to announce one thing, that next week there will be a very important lecture on how to read simple X-ray test. So this is so important, and this is the Dr. Thulkar is such a brilliant speaker. that even if you don't want to understand, he will make you understand that how to read a simple normal X-ray and how to read a simple normal pathology which we encounter day to day in practice in palliative care. For example, many times we will see a patient who is deteriorating and dyspneic, and how to recognize a patient with simple lung metastasis, how to recognize a patient lung metastasis versus lymphangitis carcinomatosis, how to recognize a patient with the aspirated, who is aspirated and in the and pneumonia. Simple things he will make you understand. So please don't miss this lecture, and those who are listening this announcement, please convey this to your friends that they should not miss that lecture at all. So next week we will see you. Dr. Nandini has one question. Arun, can you address that question, please?
So one question from Stan, one comment from Dr. Nandini, and there is one more question in the middle. So I'll go with the order of questioning. First question was that, do we change Urobags every 7 to 10 days, or what is the interval for changing Urobags?
They have no, it is not mentioned there anywhere that we should change the Urobag every 7 to 10 days. We can keep it if it is not soiled, but if we find that if it is torn or if it is, we need to change it, then only we can change it. If we have maintained a proper closed drainage system where we are taking care of the Urobags and the whole catheter set, then we need not change it after every 7 to 10 days. No recommendation for per se as to when to change the Urobag, like every 7 to 10 days. But if it is soiled, if it is torn, if it is leaking, then definitely we need to change it.
Okay, so Stan, please go ahead.
Thank you, Swati. That was excellent. The question I want to request is, when a patient is being sent home, it's not easy to manage a long line like this at home. So would you change over to the subcut line and some details about how you would manage that?
So you mean about the central lines?
Yes, because it is central line you're sending patients so that you can give the medication at home, isn't it?
So actually, hence we have the tunneled central lines, and we also have the peripherally inserted central catheters, which are put into the cephalic or the basilic vein. They are very easier to manage. In our setup also, we see patients who maintain the central lines when they are placed in the cephalic or basilic veins, and other patients who have tunneled catheters or a porta catheter, that is very easy to maintain because the whole set is inside the skin. The catheter and the ports are inside the skin. So just a simple washing is all that is required. And for the Hickman catheters also, and for the other catheters, for PICC lines, all the whole line is inside the cephalic vein and only the ports are outside. So that is also very easy to maintain. So the whole line is not outside. We do not send the patient on the central lines to home because they are only placed in ICU setup for 7 to 10 days if we have require the central lines. But for long-term infusion, we are usually maintaining that home. And we advise them routine flushing of the lines are advised to the patients.
Yeah, it is a simple way of, for the family to continue with intermittent medication. It may be simpler for them to have an alternative like a subcut line.
Okay.
So the time doctor is telling most of the time. Yeah, go ahead, Swati. Go ahead.
No, ma'am, I just wanted to say that in our setup, we have seen that mostly patients, we do not send on central lines to home because the central lines will definitely be difficult to manage. Only patients who require long-term access, we put a tunneled central lines, which are easier to manage because the whole thing is under the skin.
Yeah. No. As you said, you don't send them, but then what is the way if they cannot swallow, they need a subcut line. That's what I'm trying to say.
I think that the indication of just keeping and sending patient with central line will be absolutely different. If a person is on
palliative chemo, for example, CA colon patient is on palliative chemo, then they would like to keep this line for 6 weeks or sometime for 3 months or 6 months.
Yes,
That
yes.
time only we send patients at home with central line. Otherwise, we don't send patient with central line. Subcutaneous line is different indication, like if you want to give pain medication or if you want to give intermittent medication for vomiting or morphine or sometimes only for hydration, that will be a different indication. So most of the time we remove the line before sending. Otherwise, if at all necessary, we teach patients and their relatives thoroughly how to take care of the line at home.
Yeah. No, I was just emphasizing that aspect. That's all.
Yes.
So Arun,
Thank you, Stan. Yes, the next comment is clean intermittent self-catheterization can be an important alternative. I think, do you have any comments on this, Dr. Bhan?
This is, I think, in setups where the patient has urinary retention, then they self do it. We have not dealt with it in this seminar. This is an entirely different thing. What we thought, what we wanted, intention was to treat how to manage a Foley's catheter in patients with where it is required to use a Foley's catheter. This clean intermittent self-catheterization is an alternative where the patient himself catheterizes and he removes this catheter on his own and he does it intermittently. This is an entirely different indication. We've not dealt with it here. We just wanted to specify how to maintain a Foley's catheter.
for that also self catheterization, I think we should teach properly, because that also is an method that patient should learn properly, because although indication will be different when there is a central axle injury or caudal injury or spinal cord compression patient, if they want to do self catheterization, they don't want to keep catheter at all for a long time, then okay, unmute.
Yes.
So, Dr. Nandini wants to say, and please unmute Archana, Dr. Nandini. So then I think we should self-catheterization, we should teach properly the patient. Go ahead,
Yeah.
Nandini.
Thank you, Sushma. I just wanted to make a point that when, Swati made an excellent presentation and she talked about, using the indwelling catheter to the minimum. That is the priority to prevent infections. So then what? Suppose a person who's fully conscious and who has, some issue with the urinary retention. We don't, like in earlier days when, about 10 years ago also, it was common practice to catheterize them. So we need to, when we say don't use indwelling catheter, we also need, as a matter of prevention, we need to give an alternative. So that is why I made that point. Swati, your point is valid. And, your talk was on prevention. But when you say not to use it and minimize usage, you need to give an alternative in those who can be managed without an indwelling. That's the only point. Thank you.
Okay, ma'am. Thank you.
Okay, thank you. To this last question, and then we can terminate the session. So it is about how long can we keep a silicone catheter, please?
Silicone catheters can be kept for months, like 3 months to 6 months can be. We can keep the silicone catheters. And once, even if we have an indication like the patient presents with symptoms of UTI, then of course we need to change it earlier, but it can be kept for a period of 3 months.
Thank you for the answer. And with that, we are at the end of the session. Dr. Bhatnagar, please.
Okay, so we have 2 more minutes, and then just again, I want to emphasize that please don't miss the next week lecture. That will be the last lecture of this series, and then we will start next series with the very wonderful ideas we have put in the next series. So don't miss the last lecture of this series, and then we will start the next series of lectures. So thank you very much. Thank you, Archana and Nisha. Thank you, Arun. Thank you everyone for joining, because your presence really makes a huge difference. It encourages participants and it encourages Indian Association of Palliative Care that these lecture series are important and we should continue these lecture series. Thanks a lot. Have a nice week. We'll see you next week exactly before 6:30, and we will start at sharp 6:30. Thank you very much.